Good morning, dear colleagues. A very warm welcome from my side. My name is Gerd Burmester, and I'm from Berlin, not too far away, actually only 30 minutes by plane. And I would like to welcome to our session entitled Methotrexate in Current Clinical Practice Optimizing the Anchor Drug in Rheumatoid Arthritis Therapy. And with these words, I would also like to thank Medac for having organized this, I guess, quite exciting symposium, because we will learn a lot of new things, not only about methotrexate, but also patient approach and other questions. And those of you who managed to get into room A3 yesterday, who was there when Professor Smolin gave his presentation? So not that many so far. So there, in the management recommendations for rheumatoid arthritis, methotrexate remains the anchor drug. So there was no change regarding methotrexate as the first drug to start with, and using methotrexate as the bodyguard that Professor Feist will point out later when you treat with other DMARDs. So that hasn't changed, but of course our knowledge around methotrexate and how to deal with methotrexate has changed tremendously. And with these words, I'm very happy that we have among us Professor Mikkel Osterggard from Denmark, very close by in Copenhagen. Will be talking on the role of subcutaneous methotrexate in the treatment of patients with rheumatoid arthritis. And it will be quite interesting because we in Germany start with sub-Q. In other countries, oral administration is used. We will then proceed to the question what to do with methotrexate treatment when you vaccinate a patient against COVID. And I will address this. And we will then have, as I mentioned, the bodyguard of biologics, combination therapy, by Professor Feist, also not too far away from Magdeburg, Germany, in the university, rheumatology there. And finally, we will move to Britain. I just learned from Dr Koduri that it's constantly raining now in Britain due to the climate change. And so all the rain now goes to Britain, and we get very little rain now in Germany. And there actually has been a drought in the recent 2 years, and that is already affecting the climate change. And we also experience a very hot climate here in this room, and in order to accommodate for us for things to come. And then we will have the discussion. And please submit your questions during the meeting using this QR code. So you can scan it into your smartphone, you can put in the question, and this question will then show up on my screen towards my right now, and then we can accommodate the questions later after all the talks, because otherwise we do not know if we are exactly on time, because we need to leave the room exactly on time, and we are also online screened. And I would also like to welcome all the colleagues from outside Copenhagen who are with us via the internet. And with these words, Mikkel, we're looking forward very much to your talk and the very interesting findings regarding subcutaneous methotrexate.
Thank you very much, and also thank you for being so many so early in the morning. It's a pleasure to speak to you here in my home city of Copenhagen, and I'm also very happy now that Professor Burmester has mentioned the rain, that it's not as it was in 2009, where EULAR was last year, where we had the worst weather ever in June, and everybody not familiar with being here thought that that was how the weather always is. But it's not, and it's pretty okay these days, so I hope it will continue that way and you will enjoy it. But anyway, thank you for the opportunity to talk about, you could say, methotrexate treatment, subcutaneous and oral. It's a very clinically important topic, and I'm glad for the opportunity. So, this is my disclosures. So, I will start out from where Professor Burmester actually you could say, also mentioned that it's a very important part of how we treat our patients. The different recommendations, including not the least the EULAR recommendations for management of rheumatoid arthritis, state very clearly that methotrexate should be part of the first treatment strategy in rheumatoid arthritis, and that is both because it's efficacious in itself, but also because it's a basis for combination therapies, both with glucocorticoids, with other conventional synthetic DMARDs, and with biological DMARDs. It's also mentioned discussion around oral and subcutaneously, but that it should be given up to a dose of 25 milligrams per week and with folic acid supplementation. But it is the anchor drug in RA. I will show you some studies which has compared different aspects of methotrexate treatment. This one, the first here by Schiff and co-workers from the US, is addressing a head-to-head crossover study of oral versus subcutaneous methotrexate in RA patients. And what they did here was that they took a group of patients with RA and then gave them various doses of methotrexate, 10, 15, 20, 25 doses at random time points, and gave it in oral dosing and in subcutaneously in the thigh and subcutaneous in the abdomen, and then looked at the bioavailability afterwards in blood samples. And when you look at the curve on the right, that's the main thing, that's the area under the curve. So the availability, you'll see that when you give oral methotrexate, it's linear here up to 15 milligrams, but thereafter there is a plateau. So the bioavailability is not increasing after that dose. While with the subcutaneous dosing, it's more linear and depending on the dose given, and reach a higher level. So that's interesting, also illustrating the higher bioavailability of subcutaneous administration. This is a study from Braun in Germany, who looked into a randomized trial of quite many patients, 180 patients in two arms, one subcutaneous and one oral in methotrexate naive patients, with a outcome here at week 16. And then there was looked at different things. Important thing was the ACR responses. And you notice that the levels of ACR 20 response and 70 response were statistically significantly higher in those patients that received a subcutaneous compared to oral, while there was a marginal difference numerically in ACR 50, but not statistically significant. They also looked into other things, such as in patients who had less than or had more than 1 year since the diagnosis, who started treatment there, and there the difference between the two different arms was higher, and also that the time point where the ACR 20 was achieved in those patients were 2 weeks earlier, so there was also a time advantage in that study. There's been a meta-analysis published in 2019 by Bujor. I'm not entirely sure how it should be pronounced, I apologize for that, but who looked at ACR 20 responses in clinical trials that had used equivalent doses of oral versus subcutaneous methotrexate. And as you'll see, that even some of the studies are not really getting away from the one line, which is says the same efficacy, but if you add them all up, then there is a clear benefit from using parenteral compared to oral methotrexate with an odds ratio of an ACR 20 of around 3. This is a cohort study from Canada where they looked into patients, around 1,500 patients with rheumatoid arthritis in a cohort, and looked into various administrations of methotrexate and combinations. But the most important thing here is that there was a number of patients who received methotrexate monotherapy orally, and there was another group who received methotrexate monotherapy subcutaneously. And if you look into the the graph here, then you'll see that the survival curves illustrates that the survival of being on subcutaneous treatment was higher, so that the drug remained for a longer time. If the patients were on average followed for 3 years, and there was a significantly higher proportion also that did not need to change within those that follow-up period. And overall, if you look at hazard ratios for a treatment change, you can see that if you compare subcutaneous with the reference of all, then it was approximately 0.5. So patients on subcutaneously methotrexate changed less frequently and remained longer on therapy than those on oral methotrexate in this cohort. Then there is a study here by Rutkowska-Sak, who looked into side effects. There's also a Danish study by dermatologists who looked into this with gastrointestinal safety, and that was showing kind of the same thing, that there is less gastrointestinal side effects when you give it in a subcutaneous fashion, which is probably not surprising from what we see in our clinical practice. But nausea, intensity and frequency of discomfort, and also frequency of vomiting was, as you see it on the graph. The mentioned meta-analysis I mentioned before also looked into adverse events. And if you look at any adverse events that were experienced and add up the different studies in this meta-analysis, you'll see that there were no difference. It was very close to 1. So no difference. Regarding adverse events leading to discontinuations down here, there was also no significant difference, although you can see that there was probably a trend here. It is somewhat on the favors parenteral side, but not statistically significant. But at least absolutely not worse. Right. So then there is a different study here with few patients, 10 RA patients, which were switching from oral to subcutaneous methotrexate. It was done in the US, has only been presented as an abstract. But it showed that long-chain methotrexate polyglycamates, they increased after receiving subcutaneous rather than oral, so you can see that it increases. And even more importantly, the DAS28 was reduced. And there was a relation or an association between this increase in methotrexate polyglutamate and the disease activity decrease, suggesting that it's, of course, not a coincidence, but it's actually related. Right. So the last thing I would like to mention is also how we here in Denmark and in Scandinavia have used methotrexate in an investigator-initiated large of more than 800 early rheumatoid arthritis patients. It was presented yesterday, where we looked at early rheumatoid arthritis, less than 2 years duration, active with DAS28 above 3.2 and at least 2 swollen and 2 tender joints, and having either rheumatoid factor, NCCP or CRP positivity. They were then randomized into a conventional arm, active conventional therapy, and these 3 arms all in combination with methotrexate, but because we considered that would be the optimal treatment. So we tried to compare optimal utility of both the conventional DMARDs and 3 different mode of actions biologics. Then we looked into, one thing should be said, that the conventional therapy was methotrexate, and in some countries that was participating, it was oral prednisolone, and in others it was combined with sulfasalazine, hydroxychloroquine, and intra-articular steroids, which we, for instance, use a lot here in Denmark. So we were one of the intra-articular countries. And then we looked into a clinical outcome, CDI remission at 24 weeks, and now just presented yesterday, the clinical and radiographic outcomes at week 48. And then there's also an follow-up, but that is not so important, and we don't know the data yet. So this is at week 24, and the interesting thing here, probably mainly today, is that with methotrexate and short-term bridging corticosteroids, the CDI remission rates were actually quite high as this, as you can see here, 45% approximately, or 42% approximately, even though it's numerically slightly lower than the biological drugs here, then you could achieve this with methotrexate plus short-time steroids. If you then look at week 48, that was what I presented yesterday there, you can see that then the difference is higher, and now the patients are no longer receiving steroids, but still the remission rates on only conventional DMARDs were 40%, but higher in the other arms numerically, and also both satralizumab and abatacept together with methotrexate gave statistically significantly higher remission rates than the active conventional therapy. There were no differences in X-ray progression, but what I want to show with this is just that methotrexate plus various combinations are working very well in clinical early rheumatoid arthritis. This is again 800 patients in the 5 Nordic countries and the Netherlands. This illustrates the utility of methotrexate in different combinations. So in conclusion, I would like to highlight that international guidelines, including the EULAR recommendations, recommend that methotrexate is part of the initial treatment with RA based on how it works alone and also how it works in combination with other drugs. And that there are several advantages of subcutaneous administration, being an increased bioavailability, particularly in the higher doses, a more rapid and a better clinical efficacy on the average, and less side effects on the gastrointestinal side. And thereby, I think that use of parenteral methotrexate may lead to better disease control, and there's also a potential for reducing the need for biological therapies. So with that, and an image of our research group in Copenhagen here, Copenhagen Center for Arthritis Research, I would like to thank you for your attention.
So thank you very much, Mikkel, for this excellent presentation and leading us into the way. I encourage you to submit your questions using the QR code here via your smartphone. Of course, we have also, I think, 1 or 2 microphones here that we can use later on. And again, we will have the discussion towards the end of all of our contributions. So the next question, of course, which I believe is quite interesting, and when we started in the COVID era, we had no ideas how to treat our patients, and also when the vaccination came, people said, well, should we pause methotrexate? What about glucocorticoids and other drugs? And I will allude to this, but there was a complete uncertainty. And luckily, there had been one interesting study by Korean colleagues showing that pausing methotrexate would give you a better influenza serological response. So that was a very, very important observation, actually the only one really at that time, and that led us to study this more in detail regarding our favorite drug, I would say, or anchor drug, methotrexate. So these are my disclosures, and so what do we know? So we know that SARS-CoV-2 virus has infected hundreds of millions of people worldwide and caused at least 15 million deaths, probably way more. There is enormous knowledge about SARS-CoV-2 and COVID-19, so we know much more about prevention, diagnostics, and treatments. And since only these have led to the possibility for all of us to sit here in this room, if we had not the vaccinations and knowing how to deal with it, we would still be at home watching in our TVs, set our monitors. And this is all due, we should realize this, due to the remarkable success. So to conquer the plague took 600 years, and to battle at least in major parts SARS-CoV-2 only took 2 years, but still. And so now let's go to methotrexate. We know that this is a very important anchor drug, still the most prescribed anti-inflammatory drug with 1 million methotrexate patients in the United States alone. So this is really a significant proportion. We know that various immunosuppressants reduce the immune response after COVID-19 vaccination, and 40% to 40% of hospitalized breakthrough infections happen to the immunocompromised. These are the patients that are very close to our hearts, of course. And recently, methotrexate had also been shown to reduce the serological response after COVID-19 vaccination when the first studies came out, and the discontinuation of immunosuppressive medication can improve the vaccination response also, and in a parallel study using mycophenolate. So a reduced vaccination response was first described in 2016, and as I mentioned, pausing methotrexate 2 weeks before and after vaccination, only 2 weeks after vaccination, was also successful, and the time after and not before of the vaccination was decisive. So, and I will come to that in a minute. So therefore, all current recommendations for COVID-19 vaccinations under methotrexate therapy are based, or were based at that time, only on the influenza vaccines, and we tried to tackle this problem in a study which we called Vaccimoon in Berlin, where we investigated hundreds of patients with various immunomodulatory treatments and inflammatory rheumatic diseases. So let me just come to this study from our Korean colleagues. This letter actually is a follow-up of their initial study, where they had paused methotrexate prior to the vaccination and after. And of course, the question was, if you do this for 4 weeks, then of course there might be a flare. So we don't want to discontinue methotrexate for too long a time. So the question they then ask, what about if we only pause it after the vaccination? And that was the answer. So you see it on the box: RA disease activity, seropositivity, or use of conventional or disease-modifying anti-rheumatic drug had no additional effect over methotrexate. That was interesting in that study regarding flu vaccination. So therefore, patients taking higher doses of methotrexate appeared to benefit more from a methotrexate discontinuation, and the conclusion was patients with rheumatoid arthritis should hold methotrexate for 2 weeks after vaccination, and importantly, regardless of the time of their last dose prior to vaccination. And so let's have a brief look how antibodies are dealt with in the body. And we know that immunoglobulins or antibodies, including those generated by vaccination, they have complex pharmacokinetics. So they are taken up by usually the macrophage system, and then, as you see here, degraded, because obviously if we maintained all of our levels of antibodies all the time, there would be no blood flow anymore, because we would be full of immunoglobulins, which we do no longer need, because the virus or the bacterium is already gone. On the other hand, if the virus comes back, we need some level. So this is really remarkably generated and regulated by the immune system. And you also know that there is a special system in the newborn, so that there even you maintain higher levels for much longer time, because the newborn needs it, because they don't have their own antibodies yet. So the pharmacokinetics that also influence antibodies against viral components, in our case, are disease-related. They are also related towards the current treatment, and of course also to disease activity. So one example here, And interestingly, a presentation was shown yesterday, and also in Mikkel's session, that addressed the question, well, how much methotrexate do you need in order to have a very good response? And it turned out that in our concerted study it was about 10%, but 10 milligrams. But here we could also see what about anti-drug antibody concentrations, and here you see that if you have lower methotrexate levels, the anti-drug response is stronger. So methotrexate also is working on these antibodies against our biologics. So now let's go to vaccination, and the research question that we asked, what about pausing methotrexate following COVID-19 vaccination? And we did a retrospective study, so we asked all of our patients, several hundreds actually, and we investigated some of them, of course, about the factors influencing the immune response in patients with rheumatic diseases receiving their second SARS-CoV-2 vaccination, and looked for age, methotrexate, therapy pause versus continuation. And so when the patients came in and had been vaccinated, and we had to be very quick, it could not be a randomized controlled trial at that time, because we couldn't wait for all the paperwork to be finished, and by that time all the patients would have already been vaccinated. So we had to do it this way and ask the patient, well, did you pause or did you continue? And so, but the patients actually, they recorded this quite meticulously, and so that's why the information is really valid, and we could publish this quite recently. And so when we look for the two groups, methotrexate continuation group, methotrexate pausing group, and the decision to pause or to continue had been made by the patients themselves, mostly, but sometimes on the advice of the GP, sometimes on the advice of the rheumatologist. So the use of the BioNTech vaccine was about 75% on average in all of them, and you see the various diseases, the age group, and also, this is very important, below 60 and above 60. So the study outline, patients with autoimmune rheumatic diseases, we had information for 85, and there were methotrexate mono or combination therapy in 64, in 21 no immunomodulators, and we could focus on those who continued and those who paused methotrexate. And here are the results. You see the neutralizing capacity of the antibodies that were present in the sera of our patients. And there is a threshold, and we can argue, and we can discuss this later on, how this relates really to COVID disease and also on the protective capacity of these antibodies, which is not easy to say. But of course, if they neutralize the virus, it is a very good information, and the cutoff is about 30%. It may be very arbitrary. But when you already look here, no therapy and methotrexate therapy on the left-hand side, you see that really there are quite a few patients on methotrexate who had a poorer neutralization capacity. When you then focus on the group that continued methotrexate versus methotrexate hold, you saw that with one exception, all of these patients were above the threshold of 30%, while many of those who continued methotrexate were below 30%. And the next question was, well, what are the characteristics of this population? And then it turned out that the age was very important. So if you were below 60 years of age, then really you see no major difference between holding and continuation. However, when you look into the older population above 60 years old, only one individual was below the threshold. All the others were above, and that was highly significant, as you can see here. And so we can continue with a message. What does this knowledge add? So we identified older age above 60 years and methotrexate continuation as a critical factor for an inadequate antibody response. And when we looked into the time point, it was on average a minimum of 10 days between vaccination and the resuming of methotrexate as the clinical threshold to increase immunogenicity for these patients. So our data suggests that especially older methotrexate patients should hold methotrexate for at least 10 days after receiving a COVID-19 vaccination, if possible. And you may ask about the disease flares after pausing methotrexate, and this was a very rare event because it was 10 to 14 days and we didn't really see flares in our patients. But what else is known about this subject? And as I mentioned, there has been a case series looking into mycophenolate therapy, and also here the colleagues found that personalized approaches to paravaccination immunosuppression, it will be a key in these patients, and to stop mycophenolate or to reduce it for a while, which we sometimes know is very difficult in certain diseases, very difficult in the transplant situation, but also these data were shown here. And a little later came out this study from the Australian colleagues, also looking into the antibody response in both the AstraZeneca and the BioNTech, and in the rescue study. And I would just like to focus you on the bottom line here. So following the first and second vaccine dose, the mean SARS-CoV-2 antibody titer were significantly lower in the continued therapy compared with the control group, so also supporting the findings that we had made in our trial. And so how might this also impact clinical practice? At the bottom of the slide, full vaccination with at least 2 doses, preferable with the messenger RNA, is recommended in those with IMD, and withholding targeted synthetic DMARD therapy specifically after SARS-CoV-2 vaccination is also a recommended strategy to improve antibody response. We are focusing here in this symposium on methotrexate, of course, but it appears to be true for the JAK inhibitors as well. So the overall key messages in our study, Vaccimoon. So patients receiving methotrexate have a reduced immune response after COVID-19 vaccination, and holding methotrexate has shown to increase the immunogenicity after influenza vaccination. Our study also identified older age, above 60, and methotrexate continuation as a critical factor for an inadequate immune response, as noted in this test. And there was a minimum of 10 days between vaccination and re-intake of methotrexate as the critical threshold in these patients above 60 years old. So our recommendation from that study, especially older methotrexate patients, should hold methotrexate for at least 10 days after receiving a COVID-19 vaccination, if possible. What about the mycophenolate study? Also, a temporary hold in mycophenolate therapy is safe and augments the human response to SARS-CoV-2 vaccination in diverse patients with rheumatic and musculoskeletal diseases. And finally, regarding targeted synthetic DMARDs, our Australian colleagues recommend withholding these therapies specifically after SARS-CoV-2 vaccination is a recommended strategy to improve antibody response. And with these words, I thank you very much for your attention. And again, for time reasons, we will discuss all of our talks towards the end. Please submit your questions via the QR code. And it's now a pleasure to hand over to Prof Feist, a long working companion of mine who is now moved to the University Rheumatology of Magdeburg, not too far away. And he will talk about the bodyguard of our drugs, namely methotrexate. And we are really looking forward to your talk, Eugen.
Thank you very much, Gerd, for this nice introduction. It's a real pleasure to be this morning with you here in this audience and to give you this presentation. And I'm pretty sure each of you could give this presentation instead of me, and maybe performing even better than me with respect to this topic. Because methotrexate is not only a bodyguard of biologics, it is our best friend. I think it is hard to imagine that there is another drug that we prescribe more frequently than methotrexate. And so it's really of importance to look into existing and new data to understand better and better how these drugs work, how we should use it, like Gerd told us, in a situation where we have to vaccine our patients, how to place it in the treatment guidelines of different diseases, and of course, especially in the guidelines of rheumatoid arthritis. I think I don't have to convince you that methotrexate is a multi-talented drug. You all have used it in very different indications, not only in RA, but also in other diseases, also not only in patients with inflammatory joint diseases, but also with other organ inflammation, I believe, with good efficacy and safety. So in the recommendations for RA, as we have heard yesterday, it will keep its position in all the phases of the treatment algorithm of RA. It has not lost a single centimeter off the ground in the treatment importance in rheumatoid arthritis. It is used in all situations in combination with different partners, including biologics, but also targeted synthetic DMARDs. And you see, it is still something that you should add, if possible, in the treatment of RA. And the reason for saying so is the data that we have. And also new meta-analysis confirm the positioning of methotrexate here, showing that even in comparison with other conventional synthetic DMARDs, there seems to be an advantage of methotrexate over leflunomide, over sulfasalazine, if you combine it with TNF blockers. For other biologics, the situation is maybe slightly different. For leflunomide, for instance, we know that it is also a good partner in combination with rituximab, although not licensed for this use. But for TNF blockers, the most frequent biologics, it is shown in meta-analysis that there is an advantage for methotrexate quite clearly. It is a multi-linked drug, as mentioned before. You can use it with the big lads, with the cytokine blockers. You can use it with cell-targeted therapies. It is licensed in Germany, at least for the combination with abatacept and rituximab. You cannot use officially abatacept and rituximab without methotrexate in Germany. It is also a very good partner in combination with the smart molecules, with the JAK inhibitors, but also with apremilast in the treatment of other diseases than RA. And in some countries at least, it is also quite frequently used with other conventional synthetic DMARDs like leflunomide, sulfasalazine, hydroxychloroquine, although the EULAR recommendations do not really recommend such a combination therapy because the data for such a combination therapy of conventional DMARDs is not really convincing. Our Spanish colleagues have done a very nice expert opinion manuscript on methotrexate in use in combination with different biological and targeted synthetic DMARDs, and I have just extracted the 10 main recommendations out of this expert view and highlighted the level of agreement, which is always above 90%, and highlighted the most frequent used phrases in this recommendation. And these two most frequent phrases are methotrexate should be continued, whatever you do. Second most frequent used phrase is methotrexate should not be discontinued. So I think this tells you already everything. There are also other new systematic review and network meta-analysis on safety in early interventions with methotrexate, showing that if it comes to safety, also therapy with methotrexate has some advantages, of course. And we all know that the safety profile for this conventional synthetic DMARD is so well known to us that we, I think, use it in the right situation most frequently without any major issues. This brings me to the topic of safety and to the special role of methotrexate as a bodyguard for the biologics. The topic of anti-drug antibodies is maybe not in the focus of the research in the past years. But nevertheless, I think it's still important to recall that at least some of the older, I would say, biologics do have a capacity to induce anti-drug antibodies. You all know about infliximab, this chimeric antibody. You all know about adalimumab, that high percentage of your patients can develop, in fact, anti-drug antibodies. Up to 40% in some studies have shown anti-drug antibodies. And of course, in most of these patients, these anti-drug antibodies do not play maybe a significant role. But in some of them, these antibodies can really neutralize the biologic drug, and leading, therefore, to a loss of efficacy, to a secondary loss of efficacy of this drug, and also in some situations to safety problems with allergic reactions, for instance. And especially in patients with high anti-drug antibodies, it makes no sense to further increase the dosage of the biologics, because these anti-drug antibodies will simply neutralize whatever you give. And in this context, methotrexate is very important, and they should be combined over the whole period of treatment with a PDMARD if possible. As also shown yesterday in the miracle study by our Japanese colleagues, even a small dosage of methotrexate can help you in the treatment of rheumatoid arthritis, and there is a dose-dependent influence on the induction of anti-drug antibodies, which has been shown by numerous studies. Moving forward with safety aspects, which are also, of course, a very important issue if it comes to the update of the treatment guidelines in array by the EULAR, we have to recall that there are some rumors about the JAK inhibitors with respect to cardiovascular and thrombotic events. And there are some rumors also to the potential risk for malignancies if you use JAK inhibitors. I think we need, of course, more time to understand the safety profile of the JAK inhibitors better. By time, this will be possible, of course, but it takes at least 10 more years, in my opinion. So therefore, the initial idea that the JAK inhibitors will very soon replace methotrexate is not really realistic. And what we see also in the indirect comparison between the JAK inhibitors and methotrexate with respect to efficacy is, I think, a situation where we can say that methotrexate still holds its ground even in comparison with these new small molecules. And of course, the JAK inhibitors are highly effective, no doubt about this. The response here shown for ACR20 to 70 is higher in most of the study with JAK inhibitors compared to methotrexate in red. However, the response to methotrexate in this cohort of patients is also very good, with an ACR20 of 66, 50 of 40, and 70 of 20%. So this is a good result, and I think this makes us really comfortable to start with such a treatment. And if you look at the radiographic progression, the data in the comparison to JAK inhibitors also shows us very similar data, I think, to the North Star study, where we also do have a strong effect on inhibition of radiographic progression under methotrexate. Also in comparison with JAK inhibitors, there's no major difference. Of course, it seems that the JAK inhibitors show some better effects, but methotrexate again holds its ground. So in summary, I think methotrexate is not only multi-talented and multi-linked. You also know, of course, that we can apply it in very different ways. It fits always. It fits to a small fist if you use it in a small dosage. It fits to a big fist if you use it in a high dosage of up to 25 milligrams per week. And then you can use it also as a sub-Q injection that we have discussed earlier, which strikes better. But you can also use it if the patient especially likes it as a pill. And so it is adaptable, it's flexible. It is indeed our most important boxing glove in the treatment of rheumatoid arthritis and other diseases. Thank you very much for your attention.
So thank you very much, Eugen, for this very important and highly informative presentation. The first questions are coming in, very important questions, so it works. Please use the QR code for your smartphones, and then you can enter the questions. We already have questions in, so it works. Now it's a great pleasure to go to Great Britain, and we have Dr. Koduri with us. She's a consultant rheumatologist from Southend University in Essex, which is a beautiful area in Britain. But as I learned this morning, there's quite a lot of rain currently. So, so probably it's a relief to be in Copenhagen, Mikkel, where there is not that much rain as I remember with the previous Congress, where I've never seen that many broken down umbrellas in my life like in this conference. But you managed, Mikkel, to really change this tremendously. Yes. So thanks a lot. Okay, so the subject we're moving to is improving patient adherence during the treatment of rheumatoid arthritis. And indeed, this is a major problem, because we know that from Canadian studies that quite a few patients do not fill in their prescription, they don't go to the pharmacist and pick up their methotrexate. Then, of course, it cannot help if you don't take it. So patient adherence is very important. And also, there's some not background noise, sideway noise from the other room. And sometimes also the pharmacists say, well, you really want to take this poison, or the relatives say that. And how to deal with this, I think, is very important. So improving patient adherence during the treatment of rheumatoid arthritis is actually decisive in our daily management. So Guri, we're looking forward very much to your talk.
Thank you for the lovely introduction, and good morning, everyone. First of all, I would like to thank EULAR and the Medac for giving me this opportunity to talk on patient adherence. So these are my disclosures. So first of all, I would like to start with a case study. So SM is a 49-year-old gentleman who was diagnosed with rheumatoid arthritis in 2021. He is a chronic smoker with a 25-pack-year history, and he's also type 2 diabetic on 2 different medications. So his disease was predominantly in the hands and wrists and the small joints of the feet, and his initial disease activity score was 4.98. So as for the NICE guidelines, he was then started on oral methotrexate and short course of prednisolone. And he was followed up in the early arthritis clinic for disease assessment and treatment escalation as needed. But interestingly, 3 months later, his disease activity was still pretty much the same. There was not much improvement. And then at this stage, he said he was feeling nauseous and he felt unwell with abdominal pains for the first 2 or 3 days after taking methotrexate. So we then gave him the option to switch to subcutaneous methotrexate. But on further questioning, we realized that there were several reasons, including intentional. First of all, he was not keen on having a regular blood test, which is needed for methotrexate monitoring. And he also liked his beer, and he drinks small amounts of single malt whiskey every night. And he clearly lacked the understanding of the disease, the prognosis, and also the implications of not taking medications. So this leads on to the objective of this talk. I will talk about non-adherence, and I'll talk a little bit more in my next slide. And I'll also present the key slides from NRAS, which is a National Rheumatoid Arthritis Survey, which is conducted in UK along with the Medac company. And I shall talk about a little bit on the ASK. Basically, this is to structure your consultation and decision-making tools for better outcomes and for better adherence. And lastly, I would like to share what we do at Southend University Hospital in terms of education for better adherence and outcomes. So the goals of the rheumatoid arthritis treatment should be remission of rheumatoid arthritis. And we know that rheumatoid arthritis is a chronic disease, it's a chronic inflammatory joint condition, and it may lead to disability and poor quality of life and premature mortality. And we know that rheumatoid arthritis not only affects the joints, but it can also affect the other organs like cardiovascular and lung. And we know that cardiovascular disease is common in rheumatoid arthritis patients as compared to general population. And the traditional risk factors are also more prevalent in rheumatoid arthritis. Likewise, lung complications are common, in particular interstitial lung disease, which is associated with poor mortality. So EULAR recommends treat-to-target approach to achieve disease remission, if not disease remission, at least to achieve a low disease activity with either conventional disease-modifying drugs or biologics. And we should also offer these patients a regular review to assess disease activity and damage, and also observe for development of any comorbidities or extraarticular manifestations, to measure functional ability, and also to support these patients. And of course, rheumatoid arthritis is a chronic long-term condition, and it does have impact on a person's life. So we should be offering psychological support for these patients. But in real life, it's not that straightforward. We have several challenges, for example, non-adherence and also communication. The communication between patient and the physician may be poor, and also it depends on what sort of information you give and how much of information is given and how much they actually process. And self-management is really essential for any chronic conditions. But again, self-management programs may not be adequate or poor. And also patients who have multiple comorbidities, who are on multiple medications or complex treatment regimen, may not be confident enough to take control of their disease. And studies have shown that consultation time, of course, has a bearing on the outcomes. But again, in real life, there's always problems with the service and demands and capacity. In particular, in the NHS, we have big problems with the service demands and capacity. So moving on to non-adherence, evidence suggests that in rheumatoid arthritis, it is a big issue. It's reported to be between 30 and 80% of non-adherence. And again, it can be, it's not a single factor, but it could be multifactorial. The major contributing factors are polypharmacy, multiple comorbidities, patients' belief about the disease process and the medications, and also could be psychological or socioeconomic factors. So it's important that we develop strategies to improve adherence and the outcomes for better outcomes. Moving on to a National Rheumatoid Arthritis Survey. So this was conducted last year with the Medac, and basically this is to explore the patient's experiences with rheumatoid arthritis treatments, and also what were the preferences and the choices, and how to improve the adherence. So first of all, regarding the consultation time, 61% said they had less than 29 minutes of consultation. Only about 10 to 15% had longer than half an hour to 45 minutes. And at the first consultation, only about less than half of them were given information on the specific medications, and 22% actually didn't receive any information of options. They were only given one drug information, but not knowing what else they would have if the treatment fails was an important issue for them. And only about 31% were given on a range of different options if the one drug like Methotrexate fails. So majority of the patients were prescribed oral Methotrexate. Interestingly, only 9% were given choice of route regarding Methotrexate. And sadly, even 70% discontinued Methotrexate, and half of them were due to GI side effects. And only 1/5 of them received little or no information regarding the benefits of benefits or side effects of medication. So this survey clearly indicates that patients need to be involved in the decision, and also patients need to be given more time and more choices and a better understanding of the medication's benefits and risks. So moving on to ask approach. So basically this is to structure your consultation, because this survey also identified the not only the consultation time, but also the information you give to the patient is important. The quality of the information you give to the patients is very important. So the patients need to be involved in the consultation process. They need to be given enough time to address their concerns, and then share with them what needs to be done. And it should be a shared decision for improving their quality of life and also adherence. So you need to structure the consultation when you see these patients. So I would like to share what we do at Southend Hospital. So we see the patients in the early arthritis clinic, and the physician gives them the diagnosis and information on rheumatoid arthritis and the medications. We try not to overload information in the first consultation, because it's, I think, too much for a patient to take on or process the information. Then they come back within a week to attend this education session, which is run by our nurses and one of the physiotherapists. And here they're allowed to bring their family and friends to discuss their concerns. So they have time to read about the medication and the rheumatoid arthritis. So they bring all their concerns and questions. And then the nurses talk about the rheumatoid arthritis management, the flares, what should be they doing when they have infections, how long to stop the medications, the importance of the diet, exercise, and also alcohol intake and smoking. It has that impact on the arthritis. And we also provide them helpline advice if they have any queries and questions. And after this, they are given methotrexate or steroids medication, and they are followed up regularly in our early arthritis clinics. So we have audited for the past 5 years, and the feedback is very good. And we also learn from the feedback from the patients what they would need to do, what they would like to see more, and we then change our education system every year. So this is how we use the audit and feedback information to improve our education and adherence system. So patient education involved is very important, because studies have shown that patients who are well-informed and well-educated are able to manage their own condition, and that leads to better outcomes. So it not only improves the outcomes, but it also improves it heightens the patient satisfaction, and they have faith in our service. They have faith in the physician who's providing the care. So they also need to be given information on all the medication, not just one, but options and maybe combination therapy, and also a route of any drug, not only methotrexate, but also biologics. Now we have oral biologics as well as subcutaneous. So the choice always improves patients' adherence. So to summarize, the duration of consultation is important. You know, some patients have comorbidities and on multiple comorbidities and complex treatment regimens. So these patients you may need to triage for longer duration. And again, patient involvement and in the decision making is very important. You know, always involve the patient and make a patient agreed plan that might help them to adhere to medications. So from a clinician perspective, it's important to improve the outcomes, and that will also, you know, have an economic impact as well. So it's important to optimize RA treatment to better clinical outcomes and minimize. But again, patient involvement and patient choice and patient adherence is also important for outcomes. So thank you very much, and we'll take questions later on.
Well, thank you very much, Guri, for this also very nice and excellent presentation, addressing very important points. So there are already quite a few questions in, and I will join the colleagues in the panel. So the first question that came in, Mikkel, in the North Star, was this subcutaneous methotrexate or oral methotrexate, was the question. Mm-hmm.
It was oral methotrexate as a starting point, but it was
oral.
Yeah.
And would you envision, because you had 25 milligrams of methotrexate, and in the study you showed was that above 15 you do not really resorb that much anymore. So why was this decision based on oral rather than sub-Q? Probably for logistic reasons, I would assume also. Yeah.
Yeah, that's because it is for logistic reasons, and it's also because it's been you could say done that way in general practice, to start off with that and then switch if there's any problems.
And also another important question is, and maybe you all three of them can address it, because a colleague says, well, I mean, why not just split the oral dosage in order to get more drugs into the body than to have a sub-Q drug? And I can maybe later on allude to what the EMA says to it in our German guidelines allude to it, but how do you view this?
Well, it would be interesting to hear what you say about that later, but it's we don't do that. We always give it in that way, and that's been the tradition and also what has been studied, and thereby what we think we have evidence for doing. But it does, of course, make sense if you look at that with the bioavailability.
Guri, how do you handle it? Do you sometimes split the methotrexate dosage?
We do sometimes, yes. If the patients have benefited with methotrexate, but they are struggling with side effects, so sometimes we do split the dose.
Eugen?
Usually we do not split the dose. We, of course, then try to decrease it, but there are limits where we know that it will be not effective anymore. So usually we give it once per week, and what we can do is to increase the folic acid the day after. So this is something that we try sometimes. And then, of course, we try also to educate the patient to maybe avoid other drugs the same time together with methotrexate.
So just to comment, the German guidelines and also the EMA strongly argues against splitting the dosage for safety reasons, because sometimes patients mix it up, and it's already difficult enough to convince the patient to take it only once per week. Then to split the dosage is sometimes a real problem. So that's why the regulations rather focus on once weekly dosage, so that the patients don't make medication mistakes. But if you have other ideas, just let us know. So who maybe we can have a show of hands in the audience. Who would split the dosage? And who would not do this? So the majority is in favor of not doing this. To our colleagues outside who do not see the audience, I would say it's 3/4 who would not do it, and there are 1/4 who would do that. Okay, so that is, another question would be, we can also have a show of hands. Who starts a new RA patient on sub-Q methotrexate? And the next question will be, who does it with oral? So who starts with sub-Q methotrexate? Okay, and who starts with oral? So that is the vast majority. Okay, so very interesting. So the majority starts with oral, but in Germany we usually start with sub-Q, and maybe I can also involve Guri here. Interestingly, when I asked my patients, would you rather start with an injection of methotrexate or oral? Most of my patients, after having seen the arguments that Mikkel brought forward, they actually vote for sub-Q methotrexate. That was a remarkable surprise to me, that the patients don't say, no, I don't want to have an injection. Most of my patients actually prefer sub-Q because they know that everything will be in the body. You circumvent the gut system, and so I have actually no problems, only occasionally, in convincing my patients to start with sub-Q. Guri, how do you do this in Britain?
Well, I'm trying to change the guidelines now. In the BSR guidelines, it's still oral, but I feel you give them oral medication. You know, by the time it's 3 months and they're not, getting the disease is not getting under control. You lost 3 months already. So why not start subcut methotrexate, patients who have high disease activity right from the start, like moderate to severe, maybe not for mild, but for moderate to severe disease, why not start subcut methotrexate? So that's my practice, but not everyone, because that's not in the guidelines.
Yeah, in the German guidelines, just the opposite. It recommends sub-Q, and we learned this from our Swiss colleagues, actually, who did this for a long time. Eugen, how do you view this?
We usually argue for sub-Q, but of course the patients need more support to agree to a sub-Q injection than to oral pills. So we need to involve our nurses also in the procedures to convince the patients that it's nothing dangerous, it's very easy to handle and very comfortable. And then also the majority of patients agree to do sub-Q injections.
Thank you very much. And next question that came in was, what is, try to address it, is it important when, now regarding COVID vaccination, to pause before or after the vaccination? And it doesn't matter how long the methotrexate intake was when you give the vaccination. That doesn't matter. So you don't have to pause after methotrexate. It is only important to pause after the vaccination. This time period is in our study 10 days optimally, and but it doesn't matter when the methotrexate was given prior to the vaccination. So only after the vaccination, methotrexate pausing is necessary. And that was both shown in our trial and also in the influenza trial. So that makes it much easier to tell the patient just pause it once or twice, depending when methotrexate had been given. But again, a show of hands, who would pause methotrexate after vaccination with COVID? Who would do that? And who would say, no, that's too difficult? Oh, so I think we were convincing with our, so I didn't see a show of hands, so at least after my talk, everyone would pause methotrexate. Of course, if there is disease activity that allows it, and there may be some other factors, but usually it is quite well tolerated. Okay, next question that comes in is also a very important question, and maybe I can ask all three of you, the incidence of methotrexate pneumonitis and how to manage it, and are there any factors that would predict that this occurs? Maybe Eugen, if you can start.
Yeah, and pneumonitis is still something of concern if you talk to especially pulmonologists, because they are aware of the side effect more than all the other disciplines. And it takes sometimes time really to convince them that this is a very rare event, which is of course important, which you should recognize early, of course, but which is an exceptional rare thing, and should not also stop you from using methotrexate in patients with ILD. So the most talks that we are doing with respect to this topic is with our pulmonologists.
How often do you see this, and how would you measure? Gui,
I think it's very rare. I've probably seen just one in last 10 years.
Yep.
Pneumonitis, very, very rare. My other interest is interstitial lung disease. I work with some European colleagues, and a couple of years ago we published a big study on a large number of patients, and it's clearly shown that methotrexate does not cause interstitial lung disease. It may exacerbate, so you may need to do lung function tests frequently to see. It may exacerbate, but it actually does not cause. Methotrexate indeed was protective. And there's another study from UK on the early arthritis, again, looking at 2,000 patients. There was, again, it didn't show that methotrexate causes ILD. In fact, it's protective for...
Yeah, exactly. I think this was a very, very important study, and I commend you on it, because that changed our view in Germany and convinced also the pulmonologists not to discourage the patient from taking methotrexate, because sometimes the patients are methotrexate, they have some lung problem, even asthma sometimes, and then the pulmonologist, oh, you're methotrexate, this is a dangerous drug and causes pneumonitis, discontinue. Then you have a tough time sometimes to convince the patient to stay on methotrexate. And Mikkel, how would
yeah,
you
I don't have so much to add. It's very rare. I think in clinical practice it has to be acknowledged that it's there, and to investigate with you could say, the appropriate test as mentioned with when needed, but it's not a common issue for sure.
So my next show of hands, who has seen a true methotrexate pneumonitis within the last 5 years? Ah, interestingly. And who has seen pneumonitis within the last 10 years? Yeah. So it's still a rare event. I've seen maybe 3 in my entire career, so it's really a rare event. Sometimes you don't even know, is this true methotrexate pneumonitis or is this cytomegalovirus-induced pneumonitis? So it's rare, it occurs because many of our colleagues showed their hand, but I think it's a rather rare event and should not prevent us from using methotrexate. Okay, thank you very much. So next question that came in was, good question. Methotrexate and anti-TNF treatment, should we use this also in ankylosing spondylitis, for instance, to prevent anti-drug antibodies? So we know that it doesn't really work, methotrexate in ankylosing spondylitis, but why not add it to prevent anti-drug antibodies? This is the question asked by the colleague.
Maybe.
Maybe Mikkel can start here with this.
Well, there was an interesting study among, you say, in Europe, among European registries, who looked into the effect that was, it was in psoriatic arthritis, but where it actually did help the efficacy, in at least in some of the TNFs. So it even though it's not proven in the same way as it is in RA, then it's it does help. In AS, I don't think we have any evidence that it makes a difference.
Okay. So maybe Eugen, yeah.
I mean, the difference is clear that on one hand side, methotrexate is not effective with respect to the axial involvement of AS, so it makes no sense to combine it with respect to efficacy. The other question is, makes it sense to combine it to prevent anti-drug antibodies? Mm-hmm. And here the situation is also different compared to RA. For unknown reason, patients with AS do have a much lower frequency of anti-drug antibodies. Yeah. Which has been, I think, also published by Brown and colleagues some years ago.
Yeah, so maybe we think that the rheumatoid factor might influence the whole system or the B-cell system, that we have more anti-drug antibodies in rheumatoid arthritis compared to AS, and so that's why we usually do not need methotrexate on board in that particular disease. Final question, and then we will have to come to a close because we need to finish exactly on time because this room will be needed for another session, is, well, what about the combination of methotrexate and hydroxychloroquine? Is anyone using that among our panel? Maybe, Eugen, you have the microphone and then can hand over to Guri.
Yes, sometimes we're using it in this combination, especially outside RAs. So patients with lupus and predominant arthritic manifestation is a candidate, I think, for this combination where we have on the one hand side the beneficial effects of hydroxychloroquine on the vascular system and on the other hand the beneficial effect of methotrexate on the arthritic manifestation, for instance.
Yeah, we do very similar for sometimes for mild to moderate disease. Actually, they're not severe enough for biologics, but they still need a little bit more than methotrexate, so we do. And also for lupus with arthritis, we do combination of methotrexate and other connective tissue disease.
And we quite frequently use a combination of methotrexate, hydroxychloroquine, and sulfasalazine, actually. So that's definitely something that we do quite a lot.
And it's still also, also in the recommendation, it's possible to use that combination that you mentioned. It's technically not always easy to convince the patients to take all these 3 drugs, but it's still a valid approach. Okay, and with these words, I would like to thank you, all the speakers, for their excellent contributions. I would like to thank Medac again for having made this symposium possible, and you as the auditorium for having woken up so early to be with us and enjoy the symposium. And so thank you very much for your attention, and have a nice Congress. Thank you very much.